I'm Sally.
I'm McJimmy.
I'm Patricia.
So for our case, we had a 32-year-old man with olfactory hallucination and paresthesia. He came into the outpatient clinic of Massachusetts General Hospital with olfactory hallucination, which consisted of sulfur and burning odors. And he also had intermittent numbness and paresthesia on the left side of his body, as well as dental caries, which is typically an indicative of intracranial infection, but in this case, they found it to be most likely incidental. He was also on medications such as levetiracetam, which was administered for his olfactory hallucination because it indicated focal seizures in the uncus of the right temporal lobe. He was also taking dextroamphetamine, and he had no systematic symptoms. He did not report any changes in his skin or vision or joint pain, dry mouth, decreased lacrimation, or respiratory. So since his CT found a mass lesion in his right temporal lobe, they needed to run more imaging studies in order to determine the origin of the mass lesion, whether it was neoplastic or non-neoplastic. And one of the tests they ran were an MRI and a magnetic resonance spectroscopy, which did not help in differentiating whether the mass was neoplastic or non-neoplastic. Therefore, those tests were inconclusive.
But if we do take a look at the MRI, it does give us a general location of where the mass was located. It was an enhancing mass that was located in the medial right temporal lobe, which are indicated by the arrows. And it also showed that the mass was nearing in on the leptomeningeal foci along the right basis, which are indicated by the.
So these are well, they went to diagnose what the mass lesion was, and it could either be neoplastic, so tumorous in origin, or non-neoplastic. And the imaging studies showed calcification of the mass, which helped in diagnosing because this is supposed to be a long list of tumors that can cause calcification, but there are also non-neoplastic lesions such as tuberculosis and sarcoid granulomas that can also calcify. So it helped to zero in on what this could be, and then once we differentiate between neoplastic, non-neoplastic, we can go even further to figure out what he actually has.
And to distinguish between non-neoplastic and neoplastic, they found that it was a prepontine meningeal lesion, and which suggested inflammation, and inflammation ruled out neoplasmic condition. In addition, this mass was associated with a non-contiguous meningeal disease, which suggested a granulomatous disease. And in this chart, it gives a list of diseases and causes that suggest intracranial lesions that mimic neoplasms. So we were able to, as I mentioned, distinguish whether it's neoplastic or non-neoplastic. Now, in this table, it gives us a list of causes that are non-neoplastic, which include, you can't see, but infectious agents, non-infectious agents, vascular agents. So the next step would be to perform a biopsy to test for these agents here, and which is what occurred. Maxine will talk more about the granulomas being observed, but one test they performed was a stain to see if there were any infectious agents. And the stains were proved to be negative, so this allowed us to narrow down to the non-infectious, non-neoplastic conditions, which included sarcoidosis.
Patricia just stopped. So here it is showing the granulomas that were found replacing the brain parenchyma, which are the healthy tissues of the organ. And they were very The next one is showing that the granulomas were showing necrosis.
which is right here. You can see that the granulomas are condensed over here, necrosis occurring, which are indicated by the purple nuclei. And over there, they're not as prominent.
And on this one, you can see that they are around the blood, and it's and the appearance of it was in the image, and as well, and because of that, you can see that it does support the diagnosis that they found of sarcoidosis on the brain, which is known as neuro.
Yeah, so they narrowed it down to cerebral sarcoidosis, as McJaney said, due to the calcification and the prepontine lesion. However, they did notice that there was an absence of Sicca syndrome, which is associated with dry mouth and dry eyes. But although our patient did not exhibit these symptoms, it doesn't necessarily rule out sarcoidosis and another inflammation, Sjogren's syndrome, because patients can present without Sicca syndrome and without these systemic symptoms and still have a mass lesion in the brain like our patient. Then we wanted to talk more about sarcoidosis and what it is. It's the dysregulated immune response that leads to the growth of granulomas, and it's likely in response to exposures associated with like insecticides, agricultural employment, and microbial bioaerosols. So what happens is the environmental triggers interact with genetic, epigenetic, environmental, and immunologic host factors, which results in this hyperpolarized immune response. It's correlated with chromosome 5 in African Americans, specifically the annexin A11 gene. The annexin A11 gene has an essential role in the terminal phase of cell cytokinesis, and it is a protein detectable in human B cell exosomes, which are thought to induce immune response or tolerance depending on the cellular origin of these triggers. Sarcoidosis is 3 times more likely and more likely to be chronic and fatal in African Americans than European Americans. And then it also does not usually affect the central nervous system. So in around 90% of cases, sarcoidosis affects the lungs, but in only about 5 or 15% of cases, it affects the central nervous system like it did in our patient.
So as Sally mentioned, neurosarcoidosis is usually a multi-systematic disorder, but in this patient, it did not appear as such. So therefore, they had to run even more tests in order to perform a better diagnosis. So one of them was the high-resolution CT, which only showed abnormality in subdural abnormality in the focus of the Solon lymph node, which was located in the ileum.
Yeah, now we can move on to the treatment of sarcoidosis. Usually, sarcoidosis uses 2 main categories of immunosuppressive drugs, and these anti-inflammatory drugs focus on suppressing the inflammatory immune processes that occur with cytokines, as Sally mentioned. However, the 2 types are glucocorticoids and biologics. The way glucocorticoids work is that they focus on suppressing the cytokines in general, and cytokines that promote these inflammatory responses that are made in granulomas. However, for our patient, because of where the granulomas were located, which is in the parenchyma, patients with sarcoidosis that have focus of granulomas in the parenchyma, spinal cord, hypothalamus, or pituitary regions don't react fully to glucocorticoids. And when that is the case, another type of drug, which are biologics, in specific TNF alpha inhibitors, which stand for tumor necrosis factor alpha inhibitors, are used instead. And in this case, the most common type would be infliximab. And the way infliximab works is that it specifically targets the cytokine TNF alpha that are specifically made in granulomas. So it's these biologics are more targeting in terms of being more effective than glucocorticoids are. So our patient went through different dosages and different regimes for his diagnosis of sarcoidosis. He started off with prednisone and levetiracetam right after he'd been released from his surgery in the hospital. Dosages were later altered after realizing the symptoms through prednisone, which involved increased appetite, weight gain, interrupted reoccurring hiccups, and calcium and vitamin D deficiencies. And then after 3 months on prednisone, the patient moved on to a glucocorticoid sparing agent, which decreased the effects that he had on prednisone. Throughout his treatment, the patient went through multiple MRI scans, and what this revealed was that the lesion in his right temporal lobe was stable. It stabilized the prednisone, and the glucocorticoid sparing was not helping. In addition, it got worse in terms that it was spreading towards the brainstem, and because of this, even though the patient didn't want to go back on prednisone, it was recommended that he should go on again. And if that didn't work, the doctors decided that it would be important to go on infliximab, that two-minute factor that was mentioned before. Overall, we wanted to do this case because it allowed us to take a look at like this atypical case of sarcoidosis, which we don't really know about. But what's interesting is that others still don't know too much about it. Although Sally mentioned that there were like environmental factors that may have contributed, or genetic predispositions that may have contributed to sarcoidosis. Other causes aren't known yet, so it would be interesting later to see where time takes to see if we'll be able to treat such weird cases like neurosis, or maybe just sarcoidosis. Thank you. As of where we've read on the case, it was suggested that he will continue prednisone, and unless my idea would be unless the brain lesions in the brain were diminished, then yes, he would have to continue some sort of treatment. Just because, especially if it's spreading to the brainstem, very important. Our daily fun is we continue some sort of treatment, whether that be surgical treatment and continue.
Roll the dice. Inflammation to go away. You can get resolved. Disease is symptom free. Stuck on glucocorticoids.
Okay.
Infliximab. A kind side effect. Sarcoidosis resistant treatment. This is the second paper in class about neuros and other was able to resolve it, get off.
In that paper, did it present the same as this one?
Nope, it wasn't the prepon brainstem. This guy had it in the temporal lobe, and he was having auditory hallucination. Yeah, he had a different part of the brain. What? Any other questions? So you said that African Americans were what, 3 to 5 times more likely to have it. I have like a cursory understanding. In any of your exploration genetic stuff, did you find it said why the African Americans are more susceptible? Is it because there is a higher next 11 gene in African Americans, or if you were to compare Caucasians that have this same Annexa 11 mutation, does that put them at the same incidence?
Yeah, they isolated a single nucleotide polymorphism on the annexin A11 gene that also occurs in Germans, I think, but they also isolated 2 specific single nucleotide polymorphisms associated with sarcoidosis that only occur in Africans. Yeah, but it's still like ongoing research-wise.
Yeah, because the question that I had in my mind is you're talking about environmental factors and exposure to pesticides, or God knows what it is. Is there a sociological aspect to that? Exposed? Is that part of it? So that was what is the incidence overall? So 90, less than 90. How many people, like, what getting?
I don't know that specifically, but
So
yeah.
wondering if you've seen that.
Yeah, they said,
So
I have a number that's like, for African Americans at least, it's like 35.5 out of 100,000 versus 10.9 out of 100,000 for your European Americans.
Well, there's your numbers, yeah. So fairly rare, actually.
Yeah.
All right, so thank you. Last